In Africa, and particularly Ghana, it is a well-known fact that caring for a child is not a role left only for parents, but the collective responsibility of the entire society. This communal spirit is being manifested in the Upper West region of Ghana under the Nutrition and Malaria Control for Child Survival Project, a nationwide initiative of the Ministry of Health and sponsored by the World Bank.
We had earmarked 493 communities in this region to implement the project. We are implementing 400, so that means we are left with 93 at least. That is quite almost about 80% of our communities are in there. Then we have trained 1,478 volunteers to do the growth promotion, do the sensitization and all that. And out of the then health workers, we have 294 who have been trained. Now these people, every time, apart from the growth promotion we have talked of, would have to give health education to the women and children. We do vitamin A. Definitely, that has almost about getting to 85% coverage when we are giving vitamin A to the children. And then the pregnant woman up to 8 weeks after delivery. Knowing the role that nutrition plays as an underlying factor to good health, it means that the household has to take the lead, supported by the community, and definitely health, the Ghana Health Service as a collaborator would find it very, very easy to make sure that these objectives are achieved when you get the community involved in some of these processes.
The region for past 5 years has been confronted with a whole lot of malnutrition problems, especially undernutrition among the children under 5 years. The statistics that we had from 2008 from the Ghana Demographic and Health Survey results shows that our region children GAM rates, that is global acute malnutrition rate, was about 13.9. With this, when we look at it, sometimes from the field we could see that there are certain practices that our pupils are into, which really sometimes affect this or affect negatively the nutritional status. For instance, our kids or the children, what they eat, how they feed, and then when they eat, all goes a long way to affect their nutritional status. We have certain cultural beliefs that children would not usually eat. They wouldn't allow them to just eat eggs by heart because they believe this might lead them to becoming thieves when they are adults.
This municipality has a population of about 120,000 people, and we are working with 132 communities. In these communities, we also have sub-municipalities, and they are 6. We have some private facilities and a nutrition rehabilitation center within the municipality. Since the inception of this program, we have had a lot of support to be able to control nutrition and malaria. This program is a community-based program, and it has to do with community members taking or getting involved in solving their own problems. So we had to plan with the community members to select some volunteers for training to be able to support in growth monitoring in this particular program. We've been able to select about 84 volunteers in 42 communities for this particular program. We are in the process of scaling up, but we haven't actually done that for now. We are still sensitizing the communities.
To alleviate this growing problem, volunteers from various communities were selected and trained to assist community health workers in monitoring the growth of the most vulnerable of these children between the ages of 1 month and 23 months. These volunteers or community-based growth promoters organize monthly growth promotion sessions where they weigh these children, record their weights in the community register, compare the weights with previous weights, cancel the parents and guardians, and then refer the children to the community health nurses for the necessary immunizations.
Sometimes we have problems mobilizing this particular community. They are said to be difficult. So sometimes how to get them to come for outreach services. But normally in the month, the beginning of the month, we make an itinerary. Then we tell the volunteers when we are to come to their community. Then a week to the outreach service, we inform them again so that they will let the women to organize and come out. So when this place in particular, other communities, they contribute 20 pesos so that they give it to the one who will be the gong. So every month when the person beats the gong, then from that money we pay the person either 1 CD or 2 CD for announcing for the services. But here they don't contribute. So they said that when they hear, maybe when you tell one person, then the person to tell the other colleagues. So this place, that's how they do. And sometimes it's very difficult getting all of them to come for the services. So this morning when we even came, some were saying they didn't hear. That is this morning they heard that we were coming here.
Before the growth promotion started, community-based growth promotion started, we have Jambose, Mabase, Buka, Balesire coming together to benefit from CRS facts. So that was why they brought them together. So when this growth promotion came, they were already having one outreach point. So with the start, we had to train them. We had to get volunteers from Jambose and then Mabase to train for this community-based growth promotion. So with Jamboso, they have their literates who has gone to school, and then for Mabase, they still have their literate around. So for now, and then Buka has no. It wasn't a role, but we just trained some new communities. So that was in February. So they will also start with their group promotion, meaning now they are a bit separated. The problem is Jamboso has no literate. Mabase has a literate, and then Buka has a literate. So what we are trying to do is that we are trying to talk with the Jamboso and then Mabase group promoters if they could still come together as one outreach point so that they could help the Jamboso people because they have no literacy.
We have been facing a few challenges with the program. The issue of having literate volunteers in the communities is a big challenge. In some communities, you might not even find a single literate volunteer. So what we do is to try to find out from the next community if we can have some literate volunteers to support them. Some of the volunteers also have left either for they've traveled to other places and we have to replace them. So attrition among the volunteers is very high. When we also started the program, we trained a number of health workers. Currently, a number of them too have also gone for further studies. So the attrition among the health workers, attrition among the volunteers is also high. Motivation for the volunteers is a big problem. We expect that at least every month, whatever activities they carry out, we should be able to bring them together to discuss and share experiences. But because of funding problems, we are not able to hold regular meetings with the volunteers. We also think we should have at least 2 refresher trainings in a year for the volunteers, because you give them one-time training, you go and do supervision, but it's important to also remind them as to what they should be doing to support their community members. So the refresher trainings, we think, is a problem. We've not been having enough resources to hold refresher trainings for them. Then they become, maybe because of the fact that we don't call them regularly, we are not able to sustain the commitment, because they come, they work, and some of them, even reporting is a problem. They are not able to report, maybe because of the commitment. So if they are able to come every month for meetings, at least we'll be able to give them something for maybe their transport back, and that can either motivate them or make them more active in the program. So those are some of the few challenges.
Notably, when we started Nutrition and Malaria Control for Child Survival Project, or the growth promotion, which is a community-based, actually we have seen a whole lot of improvement. There has been significant improvement in the child nutrition, because the project, the way it is designed, we use volunteers from the community. These volunteers weigh the children, use the expected minimum weight tables to be able to tell whether the child is actually gaining weight, adequate weight or not. So when it is that, then the volunteer takes the woman and go through what is the problem. If it's about adequate weight gain, then they ask the woman, what are you feeding your child? And the woman will be able to tell what the child is feeding on. If it's breastfeeding, the volunteer goes on to know how do you breastfeed the child. Then from there, the volunteer is able to give counseling. And with this, we have realized that there have been improvement, because looking at those cultural practices that we're talking about, for instance, breastfeeding, exclusive breastfeeding, talking about the feeding the children with the colostrum, that is the first breast milk that comes out. It has improved because now the volunteers are from the same community, they know the cultural settings, so they use those ones to be able to counsel the mother. So once they are also from the same place and they are telling them, women are able to change. Nutrition Malaria Control for Child Survival has really come to help a lot. Not only even bringing out or helping children to grow, but they also even help the community health nurses at the child welfare centers, because once the community health nurse goes there and the group promoter is able to weigh these children, identify children who are due for certain services. For instance, children who are due for immunization, children who are supposed to take vitamin A, children who are supposed to take dewormer. All these children are being identified by the group promoter at the community level before the community health nurse gets there to give the services.
But that is not all. In the case that the parent is unable to bring the child to the GP sessions, follow-up visits are carried out by the growth promoters to the homes of the parents.
Dar to the when you win, I did not talk about your diabetes.
The guy puri.
Oh, you listen. I'm not going to be a poor. Check, I'm not going to be a beer. I know if you a more and pa Udeng, Ukillan Udeng. Check him more blanc to Dona. And your black young. Abi, what I man and no abe, our darling to one, what I man no behavior. Oma mora.
Oturuma mora sunja.
Nyelu ku yi ma vya ku mu awa ajisuari ja ko to ma mora wa to. E wo ma. Blan ka bi on nyele weti ne. Boju on to ba. On mora wa na. Kinan da man talki tuma yala. On mo fi awa mintata. Enyo to ba. Ke hele yala taga. Udana sigin boju on la na mata so ku dre sin pia ha. Una mata so ku dre sin pia. Se sin bana ana abihinga yo. Ana la bon ina kulu. Asenje ni mtinda wele ni. Yetama kalka tulo yala ake kunje mu fuo. Eba don balon. Ana la bonga an kulu biblia yala. Ka don balon tu nyo biblia wiyen onga no nya ana ma be ku jinsigi. Ki biye o tire don balon ala. Bleju ki ma be ka yeje na senje ko ta ka tulo yala. Ama an ya ka ai kama ko tulo ngara ka tugumba nyen senje ko. Iwo mawa. Ki mo ka yeje na senje ko ya. Ko mo ra be ya. Ka sima kokonin bun banana kima da pa tama dugu pogule ne na orna on samani ma bang ka omundi iwo mawa kita rabula ya abigal onale ye bunga chunga yirima ubeli jannan ana hadar kimo chewa ento rabula e mo ran pa kana da kan na beno queen chauta abigal ngo yala iwo mawa kimo chewa to blan ne le yin alga tutunun to mine
Baraka.
These home visits are a way of ensuring that